Thank you, Mr. Chairman. First of all, I would like to thank the organizing committee for accepting my presentation at your meeting. I'm just going to talk about transarterial embolization in acute GI bleed and our experience at the Royal Liverpool University Hospital in the UK. A very short background to stick to the time. Upper GI hemorrhage, main causes are peptic ulcers in more than 50% of cases. Although 90% of them are managed endoscopically, still in 10% of cases, transarterial embolization is needed. Lower GI hemorrhage, and 70% is due to diverticular disease and angiodysplasia. Of course, endoscopy is the first line of management for GI bleed, but what if endoscopy fails? The imaging modalities for GI bleed include the radioisotope studies, the technetium-99 RBC scan, and it can detect as low as 0.1 to 0.5 millimeter per minute of bleeding. Though it doesn't directly visualize the bleeding point, but it's also able to detect intermittent sources of bleeding in case it's not actively bleeding. Again, the disadvantage is not readily available in all units. Multi-detector CT angiography or multi-slice CT angiography is very accurate, very sensitive, and allows rapid localization of bleeding source. And it can detect bleeding rates as low as 0.2 mil per minute, which is better than direct diagnostic angiography and approaching technetium scan. Also, the delayed phase of the CT angiography can detect slow and intermittent bleeding, and it is widely available, which makes it very easy to perform. And also, it reduces the time for diagnostic angiography because it can take you directly to the source of bleeding and the bleeding artery, which you can tackle faster than normal. So in our study at the Royal Liverpool, we did, in 4 years, we had 57 patients referred with active GI bleed for embolization. CT angiography was done in 44 cases. 36 of them were positive, and out of these 36, 29 had positive and bleeding on angiography as well. 7 didn't show an active bleeding point on angiography. 13 patients didn't have a CT angiography and all went for a CT angiogram. Only 4 of them showed active bleeding on angiography. A very short case presentation, a selection of cases. Case number 1, it's a post-renal biopsy. Patient had a renal biopsy in the nephrology department for renal impairment, and then developed, they dropped his hemoglobin and hypotension, and you can see on the CT angiography there is active bleeding anterior to the kidney. And what we understood that the kidney was transfixed and bleeding happened anterior to the kidney. This is the angiography, and it shows bleeding coming from the wandering artery of Drummond, and we went with the catheter all the way down to the wandering artery of Drummond. This is our catheter going in circles and circles, and then we dropped coils. The most important thing in embolizing GI bleed is to embolize the front door and the back door. If you only embolize the front door, bleeding will still occur from the back door, and you can't reach it because you've closed your way to it. So you start with the back door, distal to the bleeding point, and then you bring your catheter back and embolize proximal to the bleeding point. And the second picture shows after embolization, there is no active extravasation. Another case, patient was in ICU, and a rectal tube was placed, which caused a bleeding in the rectum. This is a CT angiography showing active contrast extravasation in the rectum. And we went into the IMA and into the super selectively into the branches and dropped a couple of coils which stopped the bleeding. Another case, patient went for a GIST resection, gastrointestinal stromal tumor resection, and there was an iatrogenic laceration of the splenic artery which caused this extravasation on the CT. And you can see the extravasation on the angiogram, and the decision was to embolize the splenic artery. These are multiple coils within the splenic artery, and this is a follow-up CT scan, and you can see still the spleen is perfused with no abscess, and you can see the coils, the metal artifact of the coils in the splenic artery. Another case of duodenal ulcer with bleeding. Endoscopy was tried more than once, but failed to control the bleeding. And the way we deal with these cases in our hospital is that the endoscopist, if he can't control the bleeding, he just leaves a tag for us, a metal clip for us, so we can tackle it directly. And if you look closer to the first picture, you can see a metal clip there, and just next to it is the extravasation of the contrast into a pseudoaneurysm, a large pseudoaneurysm. And again, embolizing, wherever there is an arcade, you have to embolize the front door and the back door. And so these are multiple coils into all back doors and the front door of the GDA, the gastroduodenal artery, which completely stopped the bleeding. Another case of post-polypectomy bleeding. A patient went for a polypectomy from the right colon, and you can see on the first picture on the angiogram that there is active contrast extravasation very peripherally there in the corner there. And again, multiple coils were placed, and bleeding has stopped completely. Another case of post-laparoscopic hernia repair, which caused some injury to the colon, and you can see the active contrast extravasation next to the descending colon in the left iliac fossa, and you see very tiny branches reaching to the active contrast extravasation there. Again, two small microcoils were placed and stopped the bleeding completely in the second picture. This is my last case. It's a bit of interesting case. Patient went for a retroperitoneal operation. I don't know the exact history of the procedure, but there was a retroperitoneal surgery, and then the patient dropped his HB massively and hypotensive and everything, and you can see on CT scan large amounts of blood are seen within the stomach and bowel. And if you look closer, there is active contrast extravasation from the aorta just going directly into the duodenum. And this was diagnosed as aortoduodenal fistula. And the second step was to treat that. And the way we do that, we just put a stent graft, that like the one we use in aortic aneurysms, in EVAR, endovascular aortic repair of aortic aneurysm. And this is a stent graft, a covered stent within the aorta. Luckily in this patient, the patient was on dialysis, so the kidneys were non-functioning, so we just covered the renal arteries bilaterally. So we placed the covered stent just distal to the SMA. Conclusion, multi-slice CT is considered as a primary imaging modality in diagnosis of active GI bleed. A negative CT angiography can prevent patient having an unnecessary high-risk intervention procedure. A positive CT angiography allows earlier targeted embolization therapy, speeding patient treatment, and potentially reducing radiation and contrast media doses. And again, transarterial embolization is an effective tool for control of GI bleed. Thank you very much.